The call came in at 02:47, and Sergeant Lena Graves already had her hands inside someone's chest. Not figuratively, not the way nurses sometimes say it when they mean they're emotionally invested. She had her left hand applying direct pressure to a femoral bleed, and her right stabilizing a chest tube that the attending physician had placed at the wrong angle. And she was doing both of these things while a junior resident stood 3 feet away, looking at his own hands like he'd forgotten what they were for. The patient lived. That part mattered, that part always mattered. But nobody on the day shift found out about it, because by the time the morning team arrived for handoff, Lena Graves was in the supply room counting IV bags and documenting inventory on a clipboard that had her name at the top, and the word supply printed in block letters underneath. She had been at St. Marguerite General for 7 weeks. She had been a combat medic for 11 years. The town of Heron Falls, Ontario sits about 2 hours northwest of Ottawa, which is far enough from the capital that people there sometimes joke they have their own time zone. The hospital serves about 40,000 people across 3 rural municipalities, and on any given shift, the ER sees everything from farm equipment injuries to complicated rural births to the occasional snowmobile accident that arrives looking like something out of a trauma textbook. The staff were good. Most of them were genuinely good. But the place ran on hierarchy the way old houses run on original plumbing, technically functional, deeply resistant to change, and prone to backing up at the worst possible moments. Dr. Elaine Portis was the chief of emergency medicine. She had been at St. Marguerite for 22 years, and she ran a tight department. Her nurses were organized by seniority and by specialization, and she trusted her charge nurses to assign duties accordingly. The charge nurse on the day Lena Graves was hired was a woman named Charge Nurse Boudreau. This matters. Boudreau had reviewed Lena's application the way you might skim a restaurant menu when you've already decided what you want. She saw the nursing credentials. She saw the 4-year gap-marked contract work, international. She saw that Lena had no references from any Canadian hospital. She saw that Lena had listed her emergency training as field-based, non-institutional. What she did not see, or chose not to look for, was the 11 years of CANSOFCOM deployment records that would have told her, plainly and in official language, that the woman she was assigning to restock supply carts had done mass casualty triage in 3 combat zones, had been cross-trained in advanced surgical assist, and had been awarded the Meritorious Service Medal for actions taken under fire in a situation that the citation described as sustained hostile engagement with multiple critical casualties requiring concurrent intervention. Boudreau assigned her to supplies. Lena accepted the assignment without comment. This also mattered, not because she was passive, not because she didn't notice, but because Lena Graves had learned over 11 years that the people who announce themselves in the first 5 minutes of any situation are rarely the ones who decide how it ends. The thing about returning from deployment, the thing nobody warns you about, or maybe they do warn you and you just can't hear it yet because you're still too close to everything, is that civilian systems feel like they're moving in slow motion and yet somehow still managing to make wrong decisions faster than you'd think possible. Lena had been back in Canada for 8 months before she took the job at St. Marguerite. She'd spent those 8 months in Heron Falls because her sister lived there, and her sister had a spare room, and Lena needed to be somewhere that wasn't an apartment in Ottawa where she'd wake up at 3 a.m. to the sound of a truck backfiring and spend the next hour sitting in the kitchen with the lights off breathing. She was better now. That was what she told people when they asked, and it was mostly true in the way that most important things are mostly true. She took the job because she needed structure. She knew the supply assignment was wrong. She let it go for the same reason she'd learned to breathe slowly when the trucks went by. Not because she didn't feel the thing, but because she understood that reacting to every wrong thing would exhaust her before she got to the things that actually mattered. She filed her veteran health records with HR on her second day. She handed them directly to the administrative coordinator, a quiet man named Mr. Pellerin, and she watched him scan them with the particular expression of someone encountering something they don't have a folder for. "I'll make sure these are in your file," he said. She thanked him. She did not follow up, because following up would have meant flagging herself, and she wasn't ready to be flagged yet. She was still learning the place, still figuring out who knew what they were doing and who was performing knowing what they were doing, which is a distinction that looks small on paper and is enormous in practice. Boudreau ran the floor the way some people run meetings, with the appearance of efficiency and the substance of control. She was not cruel, exactly. She was efficient in the way that systems become efficient when they optimize for their own continuation rather than their stated purpose. She moved good nurses into comfortable positions and left them there. She managed upward skillfully and downward reflexively. She had strong opinions about whose name went on what chart and which nurses were leadership material and which nurses were good workers who thrive with clear direction, and the difference between those two categories, in Boudreau's taxonomy, had less to do with clinical skill than with something harder to name, something like familiarity or fit or the particular way certain people made Boudreau feel like the most competent person in the room. Lena, who was quiet and watchful, and who did not ask for anything and did not complain about anything, and who moved through the supply room with the organized calm of someone who had worked in environments where disorganization got people killed. Lena did not make Boudreau feel like the most competent person in the room. Boudreau solved this problem by simply not putting Lena in situations where the comparison could occur. For 7 weeks, this worked fine, and then the helicopter landed. It wasn't a Black Hawk. This is Canada, and the military flies CH-147 Chinooks and CH-146 Griffins, and the one that set down on the St. Marguerite rooftop helipad at 1422 on a Wednesday in February was a Griffin out of 8-wing Trenton, and it was carrying 2 critically injured soldiers from a training exercise gone wrong about 90 minutes north of Heron Falls, IEDs in Shishan, equipment failure. 1 soldier with blast pattern injuries to both legs and a tension pneumothorax developing on the right side. 1 soldier with traumatic brain injury, cervical spine compromise, and a blood pressure that had been dropping for the last 40 minutes in a way that meant the clock was already running. The flight medic who came off the aircraft first was a master corporal named Thiessen. He had been a medic for 6 years. He was good at his job and he knew it, and he also knew, with the immediate clarity of someone who has delivered patients under these conditions before, that the receiving team assembled at the rooftop door was looking at his patient list the way you look at a menu written in a language you studied briefly in high school. The attending physician was Dr. Hargreaves, who was a capable GP with emergency rotations on his record and no trauma surgery background. The 2 nurses with him were competent and rattled in equal measure. The team had been assembled by Boudreau, who had been notified of the inbound Medevac with 12 minutes notice and had sent the people who were available, which is a reasonable thing to do and also in this case the wrong thing to do. Thiessen looked at the team, he looked at his patients, he looked back at the team. "I need a trauma nurse," he said. "Do you have a trauma nurse? We're all emergency certified," one of the nurses said, and Thiessen did not say what he was thinking, which was that emergency certified and trauma ready were 2 different things, in the same way that knowing how to swim and knowing how to pull someone out of a rip current were 2 different things. "Is there anyone else?" he said instead. Dr. Hargreaves was already moving toward the patient, doing the right things, checking the airway, calling for equipment. He was doing his best. Everyone was doing their best. Thiessen followed with the gurney and kept the question in the back of his mind because he had learned, the way all field medics learn eventually, that in a hospital the most useful person is not always the most visible one. Lena heard the Griffin come in. She was in the supply room on the 3rd floor when the rotor sound changed pitch in the way that meant landing rather than passing, and she set down the IV bag she was holding and walked to the window and looked up at the roof and felt something shift inside her chest that she didn't have a precise civilian word for. She went back to her clipboard. She finished the count. She was heading back to the storage unit when she passed the door to the stairwell and heard voices. Urgent voices, not panicked, but moving at the frequency of people making fast decisions in a compressed timeline. She pushed the door open. A nurse she recognized from nights, Nurse Anselmi, 2nd year, was coming down from the roof stairs, phone in hand. "Do you know where Anselmi said. "We need someone who's done a needle decompression. Dr. Hargreaves is asking." Lena said, "How's the tension pneumo developing?" Anselmi blinked. "What? The patient from the Griffin. Right side tension pneumothorax. Is it still developing or has it progressed?" Anselmi stared at her for a half second in the particular way people stare when a piece of reality doesn't match the category they've placed it in. Lena Graves, supply nurse, counting IV bags. They didn't tell me specifics. Dr. Hargreaves just said, "Where are they? Trauma Bay 2. But Boudreau said. Lena was already moving. She did not announce herself when she came through the door of Trauma Bay 2. She assessed the room in the 3 seconds it took her to cross from the threshold to the bedside, the way she had been trained to do and the way she had done it more times than she could accurately count. Right side tension pneumo. Patient's trachea deviated left. Absent breath sounds right side. JVD visible. The needle that should have been in the second intercostal space was not in the second intercostal space. Move, she said, to no one in particular and everyone specifically. She did not check with Dr. Hargreaves first. This is the part that people later wanted to discuss. This is the part that Boudreau, who arrived 4 minutes later, cited in the formal incident report that she filed the following morning. But the reality of those 4 minutes, which nobody who was not in the room can fully appreciate, The reality of those 4 minutes is that the patient's oxygen saturation was at 78% and going down, and the conversation about proper channels can only happen after everyone is still alive to have it. Lena decompressed the chest with the efficiency of someone who has performed the procedure in the back of a vehicle, moving across uncertain terrain with inadequate lighting and no one to hand her instruments. She did it cleanly. She did it correctly. She called for the chest tube setup before she'd finished the needle decompression because she could already feel the clinical picture resolving into its next phase. And in her experience, the 3 seconds you save by calling ahead are worth more than they cost. Dr. Hargreaves watched her hands. He did not stop her. This is also the part that people later wanted to discuss. The patient's saturation came up to 86 by the time the chest tube was in, and it was climbing past 90 when Master Corporal Thiessen appeared in the doorway of the trauma bay. He'd been with the second patient in Bay 1, and stopped. He looked at the patient, he looked at the monitor, he looked at the nurse standing at the bedside with gloved hands and the particular posture of someone who has just done the thing, and is now already 3 steps ahead in their mind, tracking the next variable, waiting for the next number to change. Thiessen said, "Who are you?" Lena said, "Supply nurse." Thiessen was quiet for a moment, then he said, "What's your name?" She told him. He said, "Were you deployed?" She said, "That's not relevant right now." He watched her for another second, then he went back to Bay 1. The formal incident report that Boudreau filed cited several violations of protocol, proceeding without physician authorization, performing a procedure outside documented scope of assignment, failure to identify professional credentials to attending physician prior to intervention. Dr. Portis reviewed the report. Then she requested Lena's full personnel file. Then she requested Lena's military service records, which Mr. Pellerin retrieved from the folder he'd made, but apparently never flagged to anyone above him. Dr. read the records for a long time. The records described 11 years of service, 2 tours in a support capacity, 1 in an active combat role attached to a JTF-2 forward operating unit. The records described the Meritorious Service Medal and what had been done to earn it in the careful, compressed language that military citations use to describe things that are, in ordinary life, unimaginable. The records described Advanced Surgical Assist Certification, Advanced Trauma Life Support Instructor Qualification, and a commendation from the unit's medical officer that used the phrase clinical judgment under pressure 4 times in 2 paragraphs. Dr. Portis set the records down. She called Boudreau into her office. The conversation that followed is not documented in any formal record, which is perhaps appropriate, because the things Dr. Portis said to Boudreau in that office were not the kinds of things that belong in formal records. They were the kinds of things that need to be said person to person, without the mediation of institutional language, when a system has failed in a way that the system itself cannot easily acknowledge. Boudreau said very little. She left the office with the expression of someone who has been told something they already knew and had successfully not known for a long time. Master Corporal Thiessen came back to St. Marguerite the following day. This was not standard. The follow-up visit after a Medevac transfer is typically handled through official channels, a phone call, a records request, a brief conversation with the attending physician. Thiessen had done all of those things, and then he had driven 2 hours from Trenton to Heron Falls. He found Lena in the supply room. She was doing inventory again. She had her clipboard and her pen, and she was working through the count, with the focused attention she brought to everything, and she looked up when the door opened and then looked at him for a moment without saying anything. Thiessen stood in the doorway with his cap in his hands. He had been trying to figure out what to say for the entire drive, and he still hadn't found it, so he said the thing that was simply true. "Both patients are stable," he said. "The one from Bay 2 is going to lose the lower right leg, but he's alive. They're saying he wouldn't have made it another 20 minutes with the pneumo developing the way it was." Lena nodded once. "I looked up your service record," Thiessen said. "I had to go through a couple of channels. I hope that's okay." She said, "That's fine. You were attached to the unit that did the Kandahar extraction in 2019. She said nothing. "My older brother was in that unit," Thiessen said. "He was one of the ones who came back with injury." He stopped. Lena was looking at him very steadily. "I don't know if you were there," he said. "I don't know if you were the one. There were a lot of people involved. But I know that everyone who came back from that one came back because of the medical team, and I know that my brother has talked about... He talks about this one medic. He calls her Ghost. He says Ghost was the reason half of them are still alive." Lena set her clipboard down. She didn't say yes. She didn't say no. She said, "How's he doing now?" Thiessen's voice changed in a small, controlled way. "He's okay," he said. "He had a hard couple of years, but he's okay." She nodded again. "I just wanted you to know," Thiessen said, "that it mattered, that what you did then and what you did yesterday, it mattered, and I'm sorry you're in a supply room." Lena was quiet for a long moment. Don't be sorry, she finally said. I chose this. I needed somewhere quiet for a while. She picked her clipboard back up, then she set it down again. But maybe, she said, it's time to stop being quite so quiet. Dr. Portis restructured Lena's assignment the following Monday. The conversation was brief and functional. Dr. Portis was not given to apology through language. She expressed things through action, which Lena respected. The new assignment was trauma-certified emergency nursing, immediate effect, with a pathway to trauma team lead once the formal cross-credentialing of her military qualifications was complete. Boudreau was still charge nurse. The department was not large enough for a reorganization, and in any case the problem had never been Boudreau's competence. It had been Boudreau's habits, which are a harder thing to fix but not an impossible one. On Lena's first shift in the emergency bay, Boudreau handed her the patient board without comment. Lena took it. They stood beside each other for a moment in the particular silence of two people who understand that something has changed and are choosing pragmatically to simply begin from the new place rather than spend energy on the distance between the old one and this one. There's a potential MI in Bay 3, Boudreau said. 47-year-old male, chest pain radiating to the left arm, diaphoretic, ECG is on the monitor. Lena looked at the board. I'll take it, I know, Boudreau said. It was the closest she came to saying what she meant, and Lena understood it the way she had learned to understand most things in her first year back. Not through what was said, but through the gap between what was said and what could have been. 3 weeks later, there was a letter. It came through the hospital's official mail, addressed to Dr. Elaine Portis, Chief of Emergency Medicine, St. Marguerite General Hospital, Heron Falls, Ontario. The sender was the Office of the Surgeon General, Canadian Armed Forces. The letter commended the hospital for its role in the emergency stabilization of the 2 soldiers on February 12th. It commended Dr. Hargreaves by name. It noted, specifically and in official language, the clinical contribution of one Lena Graves, registered nurse, former sergeant, attached medical specialist, whose intervention had been instrumental in preventing the death of Master Corporal Dimitriou, currently recovering at the Ottawa General Rehabilitation Center. The letter further noted that Sergeant Graves had, during her service, accumulated a record of clinical excellence that the office wished to recognize formally, and enclosed was a commendation signed by the Surgeon General, which the office requested be added to Lena's personnel file. Dr. Portis walked the letter down to the emergency bay herself. It was a Tuesday afternoon, and the department was mid-shift and moving at the unhurried pace of a winter weekday in a small Ontario hospital. A child with a probable fracture in Bay 1, a complicated UTI in Bay 2, someone's grandmother who had fainted at the grocery store and was now sitting in Bay 4 eating crackers and explaining her blood pressure history to anyone who would listen. Lena was at the nursing station, updating a chart. She was wearing her scrubs and her stethoscope, and she had a pen behind her ear and a coffee that had been hot sometime around noon. Dr. Portis handed her the letter without preamble. Lena read it. Dr. Portis watched her read it. When Lena looked up, there was something in her face, not pride exactly, and not relief exactly, but something adjacent to both of them, something that looked like a door opening to a room that had been locked for a long time, and behind it, surprisingly, warmth. Thank you, Lena said. Dr. Portis said, it should have been in your file from the beginning. Lena said, yes, it should have. That was all. She folded the letter and put it in her pocket and turned back to the chart. Across the nursing station, Nurse Anselm, who had been pretending not to listen with the transparent intensity of someone who very much wants to be included in the story later, said very quietly to the wall in front of him, "Ghost." Lena did not turn around, but she smiled. And in Bay 4, someone's grandmother was still talking about her blood pressure, and outside the window the February snow was coming down over Heron Falls in the long, slow way that it does in Ontario in winter. And the hospital went on doing what hospitals do, the ordinary and the extraordinary happening side by side, in the same rooms, between the same walls, mostly at the same time, mostly without ceremony, the way it always had, the way it would keep doing, just with better paperwork.